remember, and we did a lot of fun little swaddling and all that fun stuff with our little baby. They thought I had a real baby this morning. I was like, no, not a real one. So, newborns. What do we think when we hear newborn?
Barely born.
Huh?
They're just newly born.
Newly born, which means what? Did everyone last week who was on the unit have fun holding babies and playing with babies and all that fun stuff? Did you have fun?
Yes.
Yeah, see, it's fun, right? I told you it was fun. Yes, there's some stress involved, but it's still, we like to have fun, okay? So go at it with having fun. I'm nosy, just so you're aware. I read all the journals that get submitted. I'm like, oh, let me see what they had to say. Let me see what they had to say. And I know a lot of you put in there, I was overwhelmed. And I get that, but guess what? It's new, right? It's new. We anticipate and expect you to be overwhelmed. This is a whole new area that you've never had exposure to, right? It's a new area of nursing you have zero exposure to, and so it's nerve-wracking, it's all kinds of different emotions going on, okay? But newborns are fun, right? Yes, no, not really. What do we have to do for newborns? Everything, right? Complete care. They can't do anything on their own. So what else do you think when you hear the word newborn? Crying, right? Why do they cry?
Hungry.
They have a need, usually. There's a need that they have. So either if a baby's crying, newborn's crying, what do we want to do first?
Check the diaper.
Check a diaper, right? We want to check a diaper. Why? Because who wants to sit in their own feces and urine? Nobody. Even a baby knows that, right? So check a diaper. What else would they be crying for? Hungry, right? Hungry. If the baby's already pissed off and crying and they're hungry, it's going to be really hard to get that breast in that mouth because they're already mad, right? So again, we have to anticipate all their needs before they have a need, okay? That's the ultimate goal with newborns, is we want to always be on top of it and anticipate the next need that they have. What else do you think about when you hear newborn?
No sleep.
No sleep, sleep deprived, right? Yep, definitely. Small, yeah. They're little bobbleheads. They have this heavy head that is like doing this all the time, right? So again, but what else has to happen? Adaptation, right? They have to adapt. Why do they have to adapt? What do they live in intrauterine? Fluid. A nice soundproof environment, right? A dark environment. Then what do they come out to? Bright lights and everyone yelling and screaming and all these different voices and different things. So they have to adapt to the extrauterine world. We also know, because we talked a little bit about it, they also have to have adaptation internally, which is what? Ductus arteriosus, the ductus venosus, and the foramen ovale all have to close so that those shunts close, then recirculates the blood where? To the lungs and the liver. Yeah, see, you did listen, right? So, to the lungs and the liver. So we have to have those shunts closed and the recirculation occurs, okay? All right, if there's a chart in a PowerPoint, what do you think you need to do? Know it, right? All right, so this is a comparison of a fetus to a newborn. So as I just said, their respiratory system is fluid filled. So their lungs are filled with fluid in utero. Once they come out, we have to initiate respirations, which then has the gas exchange occurring, and now the lungs have to work. So what is the ultimate goal for gas exchange to occur? The initiation of respirations within how long? 1 minute. We want them to take their first breath within 1 minute. I know one of you got to do a delivery, right? This week, see, I know everything that happens. So, you got to do a delivery. That's special. Not everyone gets to do that. But a minute of a blue baby can be quite a long time when you're staring at this baby and you're like, breathe, baby, breathe, right? You want to coach them through it. Take that breath. But we want them to initiate respirations within the first minute of life. If it takes longer than a minute, that's an anoxic event, and we can now cause cerebral palsy, all kinds of different issues. So we want initiation of respirations to occur within 1 minute. So, being that I said that 4 times within 30 seconds, do you think that's important to know? Definitely, okay? All right. So where does the gas exchange occur? In utero. That's the placenta. Remember, we have that intravillous space. That does all of the exchanging and all that of the nutrients and the oxygen, okay? When they come outside and they get their eviction notice, What's the eviction notice? Delivery and cutting of that umbilical cord. Now they gotta function on their own. That placenta's not doing anything else for them. The lungs have to take over. So that's why we want that respiration to occur. We already kind of talked a little bit about our circulation through the heart. So the pressure in the right atrium is greater in utero. The pressure in the left atrium is greater extrauterine, okay? And what the cause is here is this is all because of that ductus arteriosus, that ductus venosus, and the foramen ovale, okay? So again, we're moving everything. Then we go to our thermoregulation. So why is thermoregulation so important? In utero, what regulates their temperature? The amniotic fluid in mom, right? If mom has a temperature, what do you think that fetus is gonna be? It's gonna have a temperature, right? So again, that fluid, that amniotic fluid in mom is what regulates the temperature intrauterine. What regulates the temperature extrauterine? Brown fat, that's it right there. We can wrap a baby 900 blankets. If they don't have enough brown fat, they cannot have thermoregulation, okay? So the extrauterine environment has no cause of it, it's that brown fat. Without brown fat, they can't hold their temperature. That's why they need to go into what? An incubator, not a warmer, an incubator, because an incubator, we can set a certain temperature, it's an enclosed environment to simulate what?
In the
uterus, right? In the uterus. So the incubator is like, they need to cook longer. So think about that. They gotta cook a little longer. We put them in an incubator, okay? A warmer is a quick fix for thermoregulation, but they still have brown fat for that warmer to work. If they are premature and they don't have brown fat, they will not hold their temperature, okay? All right, so as I said, so the neonatal period is the first 28 days of life. So they are considered a neonate for the first 28 days of life. And what we need to do is, again, what is our biggest concern is breathing, right? Remember I told you in a boot camp, with our neonatal resuscitation, what is the first thing we do? Respiratory, respiratory, respiratory. In an adult, what is our first thing? Cardiovascular, 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 right? Very rarely do we do chest compressions on a neonate because 99% of the time it's all about the respiratory system because those lungs are fluid filled, and if you have fluid in your lungs, is it hard to breathe?
Yes.
Yeah, so what babies do you think tend to do better? Vaginal deliveries or C-sections?
Vaginal.
Why vaginal?
Because they're compressed.
They have that pressure, right? They get compressed to go into that birth canal and they get the squeeze. So hopefully, when they're squeezed into that birth canal, we're pushing that fluid where? Up, right? So it can get out of them. Versus a C-section, there's no squeeze, there's no pressure, so that fluid just sits in their lungs, and now we have to do what to reabsorb that fluid? What's the best way to reabsorb the fluid? Crying. Crying. Ah! So remember I said moms are like, oh, no baby, don't cry, baby, right? And we're like, cry, 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 because we want him to cry. Why do we want him to cry? To reabsorb that fluid, to get that fluid into the circulatory system and out of the lungs, okay? So again, we want that breathing. And again, you're gonna see neonates, 99% of the time, respiratory, respiratory, respiratory. The only time really it's a cardiac issue is if they have a congenital cardiac problem, okay? Usually, and we're gonna talk about congenital cardiac issues when we talk about peds. 99% is respiratory, 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 okay? What is your first intervention if they stop breathing? Stimulation, stimulation. Usually, if a baby's, I had a baby on Thursday, my grandma came out, she spoke no English, and she goes, I'm like, okay, I know what that is, right? Universal sign for she's freaking out. And I walk in, baby's blue, I turn the baby over, I stimulate the baby, goes, ah! Right? That's all we need to do. Now, if stimulation doesn't work, then what would we need? I heard somebody say it. What would we start with? Least invasive to most invasive?
Blow by.
Blow by, right? So first, if we stimulate, and how long are we gonna stimulate? About 30 to 45 seconds. You wanna get a nice stimulation, right? How, other than the back, how else can we stimulate this baby? Flicking the feet. We wanna piss them off. So anything you can do to piss off this baby, because why do we wanna piss him off?
We want them to cry.
We want him to cry, right? We want to make him cry, him or her cry. So, if this doesn't work, We're gonna do some blow-by. If blow-by doesn't work, now we need to do bag mask. We are not gonna jump to oxygen right away. A lot of times they have apneic spells. Remember, why do we count for 1 minute their respiratory rate? Because they have apneic spells. So how do they breathe? They're periodic breathers. And so they go, right? So if you're listening for 15 seconds, and that 15 seconds there's no breath, are you gonna chart 0 respirations? No, we're not going to. So that's why we listen for a whole minute, okay? All right, so our goal is, again, the closure of the ductus venosus, the ductus arteriosus, and the foramen ovale, okay? All right, I'm going to age myself now, but I have this little video that I'm gonna show you. And it's about the fetal circulation to the neonatal circulation. Again, you do have to have a complete understanding about the difference between intrauterine circulation and extrauterine, okay? So we have to know that the ductus arteriosus, the ductus venosus, and the foramen ovale must close, and the closure of those shunts then does what? It sends blood to the lungs and the liver, okay? All right. All right, so again, this just gives you another chart to show you the summary of the fetal circulation. So we have the clamping on the umbilical cord, again, that cuts off the supply chain for this neonate, and now the neonate has to function on their own without mom and the placenta. So remember that placenta is a lifeline in utero. Once that cord is cut, they now have to have the lungs work for them, and that is their lifeline there. All right, so we talked about initiation. So we want our respiratory, again, respiratory, okay? So the initiation of respiration should be within how long? 1 minute. If it goes longer than 1 minute, we have an anoxic event and we have concerns, right? So we don't want that to occur. So our goal, as soon as baby comes out, what is the first intervention we're gonna do? Stimulate, try and stimulate, right? So baby's on mom, and we're gonna take our lovely blanket, and we're going to stimulate to try and get baby to cry, okay? I heard about yours too, your baby was in the bed, huh? Yeah, I heard about that one too. I know, I was like, man, they had a fun day. All right, so what helps them breathe? Surfactant, right? We need surfactant. So what do we give mom? Betamethasone. The betamethasone is what helps the baby to develop surfactant. Without surfactant, can they breathe on their own? No, the alveoli will collapse and they will not be able to breathe. They're gonna need mechanical ventilation at that point. So we don't want that. So we wanna give them, hopefully they have surfactant. To know that they have enough surfactant, it's a 2-to-1 LS ratio for any regular baby, but a diabetic mom and diabetic baby, a baby born to a diabetic mom, they need a 3-to-1 LS ratio. They need more surfactant in their body because they're going to be making so much extra insulin, especially if mom has been uncontrolled because they've had this feed of glucose that the body's had to make extra insulin to combat. Now they don't have that supply chain of all that glucose, but the pancreas doesn't understand that, so they still make so much insulin. That's why they drop, their glucose drops. So they need more because their alveoli will collapse even faster than in a regular neonate.
So is the ratio telling us how much they have or how much they need?
How much they have. So as long as they have 2-to-1 ratio, that tells us that they're able to breathe on their own. Okay. Like I said, in a diabetic neonate born to a diabetic mom, they need 3-to-1, and it's an LS. It's a long word, just go with LS. LS ratio tells us there's enough surfactant, okay? Respiratory rate. So the respiratory rate, normal respiratory rate, bless you, is 30 to 60. Again, they are irregular, periodic breathers, right? So they'll go, as long as their apneic spell is not greater than 15 to 20 seconds, that's normal. Again, if you listen for 15 seconds and they have no breathing effort, we're not gonna chart 0. That's why we listen for a full minute, okay? So again, when you're listening, 15 seconds can be a long time. If you're listening and they're breathing, baby, right? That was only 5 seconds right there. Was that right? So again, we want to make sure. We also want to look to make sure their chest is symmetrical and their breathing effort is good. Please, 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 if you take away nothing from today, please, bless you, take away respiratory, 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 okay? Respiratory distress is the #1 concern with a neonate because they're all respiratory. I can tell you in 14 years of being a nurse, I've done chest compressions twice on a baby. But I've done a lot of oxygenation, right? Oxygenation, oxygenation, oxygenation. So we always start with oxygen before we start doing any type of chest compression. All right, so we know oxygenation is #1. What do you think our second concern is? Thermoregulation, right? Because we want them to be able to hold their body temperature, okay? So they do have thin skin, the blood vessels are close to the surface, so that's important. Again, the more preterm they are, the closer and translucent the skin is. So we want to make sure we're aware of that. They do lack the shivering ability. If they're shivering or jittery, that usually means they have low glucose, okay? It's not because they're cold usually, that's a glucose issue. Because if they're cold, they're not going to shiver. We're going to notice it because the temperature's going to be okay? All right, they also have limited use of voluntary muscle activity. So again, that's why thermoregulation and respiratory are pretty much even with our top priorities when we talk about neonates, okay? Because it's our job to keep them nice and warm, right? And if they're not nice and warm, something's happening, okay? All right, they also have a lack of subcutaneous fat. Again, we hope they have enough brown fat because brown fat is what is going to keep them nice and warm. They do not have the ability to adjust their own clothes, so they can't be like you and I and be like, oh, I'm cold, let me put a jacket on, right? We have to anticipate all their needs. So one extra layer than what we're comfortable in is perfectly fine, okay? So if we're comfortable in a t-shirt, they might need a t-shirt and 1 blanket or 2 blankets, okay? We don't need to go in there and have 1,900 blankets taking off all the layers because we don't want to overcook the babies, right? They only need one extra layer than what we're comfortable in, as long as they have what?
Brown fat.
Brown fat. We're gonna hear that over and over, right? As long as they have brown fat, because the extrauterine environment, no matter what we do, without brown fat, they cannot keep their temperature. All right, so you have different types of heat loss, and as nurses, we have to be aware of this and we have to fix it. So first you have conduction, and this involves the transfer of heat from one object to another when the two objects are in direct contact. So what do you think is one thing that we do that can cause heat loss this way?
Putting them on the scale.
The scale, right? A cold scale. What else do we use?
A table.
Our cold hands. What else? What do we put to listen to them? Our cold stethoscope, right? So we want to make sure we're not doing that. How can we help conduction heat loss? By putting baby skin to skin with mom, right? Mom can bring that temperature up. Convection involves the flow of heat from the body surface to cooler surroundings. So this can include cool drafts. So that would be open doors, windows, fans, all of that. And what do we live in? Yuma. What do we constantly have on? I know what I constantly have on. I have my AC on, right? And so we want to make sure they're not putting the babies near the AC vents and different things like that. Evaporation occurs a lot. How does evaporation occur?
Baby's wet.
Any type of liquid, right? Any type of liquid. So how could we cause evaporation to drop the temperature? Wet linens, wet diapers, when you bathe the baby, right? So that's why it's important, again, to do it quick. And then you have radiation. Radiation and convection are pretty similar to each other, but this is where it involves the loss of body heat to cooler solid surfaces that are in proximity. And again, it can include outside walls, cold windows, air conditioners as well. So we want to be aware of all of this, and we want to educate, right? We want to educate. They should be in one extra layer than we're in. They shouldn't be next to a window. We should keep them dry. We shouldn't put any cold things on them, and keep them, again, away from drafts or anything like that. All right, so as I said, thermoregulation is right up there with your oxygenation. And one of the biggest keys with thermoregulation is brown fat. Okay. Normal temperature should be 97.7 to 99.0. Again, we want to make sure that we are keeping them in that range. If they're too cold, what are we going to do? Get them warm. How do we get them warm?
Skin to skin.
Least invasive to most invasive, so skin to skin would be the first one. If mom's not effective in skin to skin, then we may need to do a warmer or something like that, okay? But we really want to try skin to skin first. That's the first intervention we would do to bring up that temperature. If they have a low temperature and we're not identifying it, they can go what's into cold stress, okay? We don't want them in cold stress. Cold stress will increase the metabolic rate, and it also will metabolize the brown fat. If they're in cold stress and they're metabolizing the brown fat, what does that tell us is going to happen? They're going to keep continuing to get cold, which then they're going to increase the metabolism of all the brown fat. And then if they have no brown fat, what can they not do? Hold their temperature, okay? So again, we want to make sure we're staying one step ahead of them, monitoring their temperature very closely. That's why in the first 4 hours, we do it constantly, right? 30 times 4, hourly times 2, because we want to make sure that thermoregulation is occurring. If they can hold their temperature for that first 4 hours, usually they're going to be good, okay? As long as we have one extra layer over. But if their glucose drops or something like that, their temperature is going to drop, and then they start metabolizing that brown fat, okay? We don't want them to metabolize that. If they are hypothermic, we can, like I said, skin to skin, and then we're also going to try some warmer if we need to. but our biggest thing is keeping that temperature up, okay? One thing, if you have a baby who has constant low temps, you're gonna start critically thinking and check the glucose level, because if their glucose is low, their temp can be low as related to that, okay? If the glucose is good, then you have to start figuring out why this temperature is low. What is going on with this neonate? He or she cannot communicate with you, so as the nurse, we have to anticipate. Are they wrapped up? Are they skin to skin properly? Are they just letting them hang out like this in the air conditioned bench, right? And you'll see all of this, you really will. And so it's our job to educate. I tell you, and I said it this weekend to somebody, how crazy, we have a student who's doing her capstone in a pediatric hospital up in Phoenix, and there was a CPS case that they took, the baby was 8 months old and already had a hematoma on their brain because of shaken baby. And she was devastated, and I said, this is what's alarming, is anybody can have a kid, but you need to take a test, a written and a driving test to get a driver's license, but we send people home with these kids who have no idea what to do. And so again, education is key. Yes?
For the two items, like the two levels, like the shirt and then the blanket, is that the full 28 days?
Usually, yeah. Because again, we always really want them, when they go home, they're gonna put them in all kinds of clothes and different things like that. Usually for the first 28 days, they like that swaddle because it makes them feel like they're back in mom's womb. But we don't wanna swaddle them for a long time, because what is that inhibiting? Gross motor, fine motor skills, movement, right? Same reason why we don't keep those mittens on them forever, because we want them to move their hands and all of that. And when we talk in 2 weeks about growth and development, and we talk about newborns again then, we're gonna talk a little bit about what should be happening during that time. But really, we send the thermometers home with them because we want them to take their temperature constantly, just to make sure they're within that range. Because if they drop and they stay low for a while, they're gonna go into cold stress. All right, so glucose is essential fuel for the brain metabolism. So do you realize that your brain uses 60% of the glucose in your body to function? So if you don't have glucose, what do you think is gonna happen with your brain? Yeah, right, well, you're gonna go to your vital organs, but the brain's gonna be foggy. It's not gonna be able to function without glucose, okay? So that's something that we all as humans need. Our brain uses 60% of our glucose to function. That's why I used to bring candy when I gave exams. I'm like, you need glucose, you need that brain to function, right? We all have to have a functioning brain. All right, now, when the placenta is lost, the glucose supply is cut off. So that's why it's important, if mom is an uncontrolled diabetic, that we monitor the glucose very closely, okay? We monitor them for 24 hours as long as their glucose at the end is within normal limits. We want, at 24 hours of life, we want the glucose above 45. Now in an adult, would you be concerned at a glucose of 45? With a neonate, that's perfect for us. We want it at 45 or above, okay? And so again, what happens if mom is uncontrolled and she eats a lot of sugar, the neonate or the fetus insulin builds all this insulin, right? So it has all this insulin. So in utero, it's able to control it because the pancreas is functioning. However, when the placenta is lost, that glucose supply is lost, the pancreas does not have any idea that we don't have that much glucose, so the pancreas keeps making all this insulin and the baby tanks, okay? So remember we talked a little bit about big dumb babies, right? They're big, but they can't get enough glucose in them to help with the insulin that the pancreas is making, okay? So again, we want to watch them and monitor them very closely. Also, they have a huge risk of hyperbilirubinemia. Say that 5 times fast, hyperbilirubinemia, right? So that is what we call jaundice, right? The jaundice is hyperbilirubinemia, and so we want to make sure that we start initiating that liver. So remember that liver didn't have much blood supply in utero. So now we have to kick that liver in and say, okay, liver, we need you to start working, and we need you to excrete the bilirubin, okay? If the liver doesn't work and doesn't excrete the bilirubin, we're gonna have concerns because it's gonna build up in their body. And we don't want the bilirubin to build up in their body. That's why we check babies Remember, we did the little TCB, right? TCB to check the transcutaneous bili. And then if it's high, we would do a serum bili, okay? Now, all O positive and RH negative moms, their baby's blood type gets checked. Why? Because we need to know what their RH factor is, but also because O positive and RH negative babies are at risk of having what's called direct Coombs. Direct Coombs says that they're gonna hit hyperbilirubinemia faster than a baby who doesn't have a direct Coombs, okay? So again, if you get a call that your baby has a direct Coombs, we're gonna be checking that bilirubin earlier than a baby who doesn't have a direct Coombs because their risk of becoming jaundice increases and intensifies. All right, also, their blood does not have vitamin K or clotting factors. That's why we give the vitamin K after delivery to initiate those clotting factors. Vitamin K is not a vaccination. It's simply some vitamin K to help initiate that, okay? Without the vitamin K, they are at risk of having a cranial hemorrhage, okay? So once you tell moms that, okay, it's not a vaccine, they're like, no, I don't want any vitamin K, okay, you're putting your baby at risk of a brain bleed. Usually when you tell them a brain bleed, they're like, okay, you can give them some vitamin K, right? Because no one wants to cause a brain bleed on their baby. If they still say no, then we say, okay, we need to let the pediatrician know, and then the pediatrician goes in and scares them and says, your baby will bleed in the brain and die, and then once you use the die word, they're like, okay, I'll give some vitamin K, okay? Most babies do. All right. You also need to be aware of medications that you give mom because it can be passed in the breast milk. Very, very few meds are off limits. We actually have our own medication book on the unit, and it's all about breast milk. What meds are safe and what meds aren't safe. Every med that you did on your medication card is safe for breastfeeding, and you'll get that question a lot. Moms will ask you, when they're in pain and you give them a Percocet or a Roxycodone, they're like, is this safe? Yes, we wouldn't give it to you if it wasn't safe for breastfeeding, okay? What is the one patient that should never breastfeed their baby? HIV positive, correct. They cannot breastfeed, no bodily fluids with that baby. Even though breast is best, we do not want HIV breast milk going to that baby. All right, so they are given 24 hours to have their first void. So we want one void and one stool before they get to go home. That first void sometimes will be red and it's called brick dust. And what it is it's the baby excreting the maternal hormones, okay? And it's the uric acid crystals. It's perfectly normal. By the time the feeding is established, they should have 6 to 10 wet diapers a day, okay? So again, lots and lots of diapers. Diapers are expensive. Diapers are not cheap, okay? So again, this is part of the education. Because do we want babies sitting in their own urine or their own feces for a long period of time? No, so they have to constantly be changing these babies. I crack up because I was doing boot camp one day and someone had taken my last diaper and I didn't have a diaper, my baby was naked and I didn't want my baby naked, so I called Brandy. I said, Brandy, I need you to go to the store and I need you to buy me some diapers. She comes with a case of diapers. She thought every student got to take a diaper home, and I'm like, no. So I have a whole case of diapers sitting in the lab, and I've used this one for a long time. So I have diapers until I die, probably. So, but I'm like, no, we don't give the students diapers. That's not a token that they get to take. But again, education, education, education. Who knows someone who used cloth diapers? Yeah, that's disgusting to me, but yeah, it's cheaper though, right? Again, socioeconomic. If they can't afford disposable diapers, then they're gonna have to wash out the pee and the poop and all of that in cloth diapers. But again, education, education. Remember I said these patients are only here 24 hours and we have to tell them all this lovely stuff within that time frame. So you don't have to memorize their hematocrit and hemoglobin. You're never going to be tested on that, but this just goes to show you there's a difference, right? Their hematocrit and hemoglobin are higher than that in adults. And that is one of the reasons why we do delayed cord clamping, because we want that rush of blood to get to that fetus, to increase the blood volume in them, anticipating any type of issues. Their GI tract is sterile at birth, and so the normal flora will come with feedings, okay? Also, what is their abdomen or GI tract filled with? Amniotic fluid, okay? So a lot of times their lungs are filled with fluid, their abdomen, and so again, we wanna make sure we're feeding them appropriately. We also wanna make sure that they have a patent anus, and that is gonna determine passage of meconium. So they have to pass meconium before they can go home, otherwise we have to figure out why they're not having a bowel movement, okay? Meconium is very sticky, it's tarry, and so if the baby has meconium, you want to get it off them very fast, otherwise you have to scrub their booty and it gets all stuck. Little boys, you have to spread their rugae and clean all between their little testicles and all of that. And so again, the longer they sit in that, the more sticky and tarry it gets and gets conformed to their booty, okay? We're going to talk about the difference between breastfed stools and bottle feeding in a little bit. All right, so their immune system. So their immune system is not there, right? Because what did they just live in? Sterile environment. So what is the first risk of infection for a neonate? When the water ruptures, right? That's the first risk of infection because that just broke what? The sterile environment, okay? So if they're ruptured for a long time, what does that put baby and mom at risk of? Risk of infection, okay? The goal is to have the baby out within 24 hours of the bag of water breaking. That's kind of the ultimate goal because their risk of infection intensifies once they've hit 24 hours. So that is why it's crucial we know when their water broke, okay, when they go into labor. If they're like, I don't know, 4 days ago, you're gonna be like, oh crap, right? We really have a risk of infection. And you do have the patients who come in and they're like, oh, I've been leaking for 4 or 5 days. And you're like, and you just decided to come to the hospital today. What made today the lucky day, right? But again, education. Anytime someone thinks they're ruptured or leaking, they need to be evaluated because the risk of infection starts then, okay? Also, if mom is GBS positive, that is a risk of infection as well. GBS is not a reason to do a C-section, okay? Not a reason to do a C-section. And you laugh because that was part of the question, right? Everyone's like, oh man! No, GBS, all we do is we get Pen-G on board and we hope to keep them not delivered for 4 hours and then they can have a vaginal delivery, okay? So again, GBS is also the risk of infection for the neonate. Remember, it's not an STI for females, it's not any issue. We can live with GBS in our vaginal canal. However, the neonate is what gets a risk of exposure, okay? All right, so what is passive immunity and why do we want to do it?
Because it gives the antibodies to the baby.
It gives the antibodies to the baby. So we give passive immunity through the breast milk, and then acquired immunity is what? Vaccinations, yep, vaccinations or exposure to antigens. An antigen is what is a foreign substance, then the body makes the antibody to combat the antigen, okay? Man, I'm going back to my Patho Farm days. I used to teach on that all the time. All right. I really miss teaching Patho Farm. That was one of my favorite classes to teach. All right. So we have to educate again. So because they have no immunity, what do we want to teach parents to not do? Bring them around sick people. Do not kiss my baby, right? No kissing my baby. There is a no kissing campaign that's out there. I had a patient it was a couple months ago, and she had a onesie that said, please don't kiss my baby. And she put the baby in because her other baby had gotten pertussis because somebody had kissed her baby and was hospitalized for 3 weeks because of severe RSV and pertussis. And so she was so adamant, like she wanted us to wear a mask around her baby. She was that adamant. But so no sick people, no large crowds, don't kiss my baby, right? Until what? Until we have acquired immunity on board, which are the vaccinations. Unfortunately, we have an influx of anti-vaxxers in the United States right now. It's gotten so bad that once measles were eradicated, we now are having cases of measles back. We're our biggest concern. Who in here knows an anti-vaxxer? Who is an anti-vaxxer anymore? Everyone's like, I'm not admitting that. They're like, Professor Wright will be on top of me of that. And so we have had measles cases. Our biggest concern in the healthcare is polio coming back because polio caused people to be paralyzed. And so we really have to push. Before COVID, I was fortunate enough to go to Washington, D.C. 2 years in a row with Professor Bradley for the American Nursing Association. And the year before COVID, we went, and the American ANA, that's like the governing board for nurses, right? They did a stance that they do not agree with anyone not vaccinating their children, and they also don't agree even if it's a religious belief, because we are seeing these disease processes come back that were once eradicated. So it's really, really important, and we talk in pediatrics a lot more about it because we talk about vaccines and different things, but we really want to educate. If they don't want the first Hep B vaccine, that's perfectly fine at the hospital. A lot of them want to talk to the pediatrician before they choose, but we really do push to have it just because we need kids to be vaccinated. All right, their neurological system, again, is immature. However, these neonates are freaking phenomenal. Remember when we talked at the beginning of the semester about the female body, how phenomenal that is, how we can grow a baby and do all that stuff? These neonates, right when they come out, they already can hear. They can hear very well. Now, sometimes they have fluid in the ears. Remember when we were doing our tour and we saw the lady in maroon bringing the crib back and forth? She's taking to do hearing screening. So all babies get hearing screenings done. If they have too much fluid, they might fail and then they come back, but they can hear and they can turn their head. Who do you think's voice they turn their head to most often?
Mom.
Mom. Why mom?
Because that's how they heard.
That's what they heard. You have the dads who are at the belly and they're like, hey baby, how are you, right? Baby hears, that's all the baby's gonna hear, okay? It's muffled because what are they living in?
Water.
Water, right? Think about it, if you're under the water, can you hear anything? No, right? So that's all they hear, but they hear mom because they're listening constantly, okay? So they're very in tune to mom's voice. Also, their smell is developed right away, and they can distinguish their own maternal milk from someone else's milk. So they can identify and smell their own mom's milk, and they know that that's their mom versus someone else. So while donor milk is good, again, they would prefer their own mother's milk. Back in the day, they used to have what was called a wet nurse, and the wet nurse would feed all the different babies because she would be lactating. I'm like, I would never want that job. Hey baby, come lunch here, right? But again, they have that innate smell that they can identify their mom's milk from someone else. They are sensitive to pain right away, so they do have that ability. Their vision, they're pretty much blind, not really blind, but very limited vision. They can only see about this far from their face, not too far. And they see in black, white, and red in the beginning. So their vision is black, white, red. And then the colors start to come in play as they develop and get older. That's why if you notice, a lot of the mobiles or different toys for newborns are black and white because that's what they see is black, white, and red, okay? Yes, you learn something every day, don't you? Yes, that's the beauty of school, right? So, also, their taste. They can distinguish sour tasting foods from other things as well. And then they also have all those lovely reflexes, which are normal. So who remembers what we do for a startle reflex?
Oh, you let them go.
This is a plastic baby, but we're gonna gently lift up and go, and they should startle out. What about Babinski?
Oh, the foot.
Right down the crease of the foot, and then the grips, the little monkey toe grips, right? They also should grip your hands, right? Those are all the reflexes that they should have, and they should all disappear as they get older. But those are gonna tell us neurological development and neurological function. All right, go ahead and take a quick 5-minute break, use the bathroom, and